Hello, I'm Mary Slavin, Director of the Dissemination Core and Co-Director of the Education Program for LeaRRn, and I'm pleased to introduce today's presentation for Year 4 of our series using health systems research to revolutionize rehabilitation care. Next slide. Please note if you'd like to enable closed captions for this webinar, there are two options in the Zoom navigation bar. You can either select closed captions if it is visible, or if it's not visible, you can select more to access the closed caption feature, then select captions, and then you can choose your preferred language. Next slide. So amazingly, today's webinar marks the 37th LeaRRn-sponsored events, and we're pleased to say that all previous events are archived on the LeaRRn website, and those events include our most recent webinar featuring Dr. Suzanne Backen's presentation on epistemic justice in advancing health informatics and data science innovations. The link to these archived presentations is now available in the chat. Again, I encourage you to go look at these archived webinars. It is really a tremendous resource. So today, I'm pleased to introduce our presentation, Social Determinants of Health Data in a Learning Health System, Implications for Rehabilitation. And we're joined by three panelists who will share their experiences collecting and using social determinants of health within their systems: Karen Mattie, Kelly Shane, and Devyn Woodfield. Karen Mattie is the Senior Director of Clinical Operations at Boston Medical Center, where she is engaged in rehabilitation clinical practice and leadership for 14 years. She has extended oversight of clinical and operational leadership of the physical, occupational, and respiratory care services, as well as adult day health programming. Over the last 4 years, Dr. Mattie and BMC have been LeaRRn Health System partners. BMC recently welcomed the 4th LeaRRn Scholar. Collaboration with scholars have led to successful implementation and evaluation of the Hopkins Activity and Mobility Program at BMC. Work with LeaRRn Scholars is also focused on using the AM-PAC as a functional outcome measure in the outpatient setting, performing analysis of patient characteristics to best apply outcome measures and further investigate acute care frequency as compared to overall measures. Dr. Mattie is an active member of the Massachusetts Health and Hospital Association Continuum of Care Council and holds an Adjunct Clinical Instructor position in the Department of Physical Therapy at Boston University. Kelly Shane is a physical therapist at Phoenix Children's. She has previously worked at Children's Specialized Hospital and Cincinnati Children's Hospital Medical Center. She graduated with a DPT from Washington University program in physical therapy. She's an active member of the APT Academy of Pediatric Physical Therapy and is chair of the hospital-based special interest group and a member of the Movement System Committee. Our third speaker today is Devyn Woodfield. Mr. Woodfield has a Master of Science in Statistics and serves as the lead data analyst for the Rehabilitation Services at Adjunct Health. His work includes the development of innovative dashboards to monitor key metrics and drive actionable insight across all therapy disciplines and care settings. He's presented at several national conferences on the topic of dashboard development, visualization, and design. Most recently, he presented the 2023 American Hospital Association Accelerating Health Equity Conference. So with that, we have our speaker list. Next slide. So as the agenda demonstrates, these presentations will be followed by a Q&A session, and we ask that you enter your questions using the Q&A feature of Zoom. After the formal presentation, speakers will join us for a panel discussion to answer your questions. And after the presentations, we'll provide a link to an evaluation survey and a brief poll to learn more about participants. Finally, we'll wrap up our time today by sharing some upcoming LeaRRn events. And with that, I'm pleased to ask Dr. Mattie to begin our presentation. Welcome, Dr. Mattie.
Thank you, Mary. I am honored to be here today, and I am looking forward to presenting on behalf of Boston Medical Center. Are my slides available? Great. Thank you, Kara. Mary, thank you for the introduction. Along my side today, I have Bryant Seaman, who is from the Medical University of South Carolina, and I also have Clarissa Martinez joining me, and she is from the University of Southern California, both LeaRRn scholars that are participating with Boston Medical Center. So welcome. Next slide. What I thought we would do today is start to define exactly what we'll be speaking about today. Social determinants of health, as defined by the U.S. Department of Health and Human Services, describes it in 5 categories seen on the screen: education access and quality, economic stability, social and community context, healthcare access and quality, which so many of us are focusing on, and neighborhood and build environment. Another great quote that I saw was that social determinants of health are the conditions where all people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. We all know that social determinants of health has a major impact on people's well-being and quality of life, and it contributes to all the wide health disparities and inequities that unfortunately we all work with every single day. Health systems and organizations must develop action plans to improve these conditions for our patients. We think we all know that health is really defined as more than just a doctor appointment at this point. And I urge everyone to think broadly about how to encourage and empower your teams to weave this into your high priority work. I'm excited today that we'll be able to share a little bit about how this plays in rehab, where we really have a key role in keeping people well. Next slide. Wanted to show you a little bit about who Boston Medical Center is, if you're unaware. We focus on coordinating equitable, value-based continuum of care to patients and health plan members. Our system is comprised of a large WellSense health plan. We are part of a Boston ACO, a Boston Health Safety Net, the BU Med Group, and Clearway Health Pharmacy. We are also the largest safety net hospital and busiest trauma and emergency service center in New England. We're a private, non-for-profit and growing, now 1,614 bed academic medical center. We are an affiliate with BU, and some demographics: 57% of our patients are underserved, 32% and growing do not speak English as their primary language. Recently, we're very proud to be Magnet recognized, and our rehabilitation services continues to grow and expand across inpatient and outpatient settings, and now with 3 community-based clinics that average about 75,000 annual visits. Next slide. What I thought I would do today is further define just one way that Boston Medical Center is addressing social determinants of health that face our patients over here in Boston. Unique to our setting is a program that many of you may have known about now. Is called Thrive. It is our screening tool and resource program that was developed in-house to systemically identify and address the patient's social risk factors and social needs. This launch was in 2017, and it was very timely to begin such a pilot with a Thrive screener, which is ultimately a questionnaire. In 2018, Mass Health transitioned to a value-based accountable care organization model, an ACO, where higher payments for claims reflected higher social complexity. And then in 2022, Mass Health in this state announced equity waivers for health, and the Joint Commission also announced health equity standards. So our work was very timely. Right now, with our Thrive screener, we have 10 plus locations within the institution where the screener is at the patient level, and they fill it out to the best of their ability in 6 different languages. From there, the medical assistant documents and completes in the EMR, and then the physician and care team is involved and empathetic and supportive and help getting patients the resources they need. And we also have patient navigators that further do outreach and help tie our patients to the care services that they need. Recently, we did an upgrade to a 2.0 Thrive, and this was very timely because of the regulatory screening and reporting requirements for health-related social needs. It's further helping us evaluate internally to help us identify pain points for improvement. We continue to deepen our relationship with a vendor called Find Help, which is actually our Thrive directory. And this is actually helping us improve grant funding opportunities to improve digital access for our patients. We have created infrastructure to support outreach workforce and improve our referral process. For the domains that are discussed, we have 15 unique Thrive resources that is helpful for our patients. So at BMC, we measure, we assess, we discuss, we document, and we really try to do something to address the social determinants of health within the communities that we serve. BMC has worked very hard establishing an infrastructure and building relationships in our community and strengthen our referral resources. Next slide. I thought wise to show you a slide on the how, and admittedly this is a little small, but this is just a snip inside of EPIC, which is our EMR. And on the left-hand side, for those that are in EPIC, there is a storyboard. This is accessible in chart review for all providers and care team members. So patient has social needs is indicated on everyone's storyboard, and you can open that up and further look into the chart. You'll see in the middle of the screen, we have our own circle of social determinants of health. There's note sections where we can further document. And then there are referral pathways as well. Next slide. Lastly, I wanted to speak just a little bit about how we are using our data sets more clearly in rehab. Through the LeaRRn project, Bryant, who is with us today, will investigate and help us better understand and gain insight into who the people are that are utilizing our care in the clinics. This project will give us the understanding into whether there are specific patient characteristics that influence how people engage with BMC, with PT and OT in particular. This can help us make decisions on adjustments that we may need to do to make sure that we are sure we meet the needs of our community and help facilitate access. We hope to have a better understanding of who is at risk for not attending or completing a plan of care of physical or occupational therapy. There may be certain programs or support systems that can be put into place to help facilitate increased or sustained engagement within our clinics. On the right-hand side of the screen, through some work here, I wanted to welcome Clarissa to our team, who is our newest member. She will be looking to understand our current utilization of rehab therapy services in acute care, particularly with the PT and OT frequency of care settings. There are many ways to quantify PT frequency. For example, the total amount of time PT was received during the entire stay, the percent of days during the hospital stay in which PT was received, or the percent of days in which PT was received relative to the recommendation or the prescribed frequency. One goal of the upcoming scholar year is to understand what the current PT frequency is at BMC and determine if the frequency impacts the length of stay or our discharge destinations. Within this work, we plan to explore how social determinants of health impact inpatient PT care here. We are trying to determine if people with high risk social determinants of health factors may need increased frequency upfront to have a better chance at good outcomes for home discharge. And with that, I would like to reintroduce Kelly from Phoenix Children's Hospital, who will dive into some great examples where she and her rehab colleagues are making a direct impact.
Hi, everyone. Thank you so much for having me today. Also, thank you to Karen for providing us with that nice systems level view. You guys are really doing some amazing work over at Boston Medical Center. As previously said, my name is Kelly Shane, and I'm here to talk to you all as rehab professionals and how we can make an impact on social determinants of health in our day-to-day or on the ground. You may be thinking, okay, I am glad that people are beginning to collect this data, but what does that mean to me as I'm here seeing a lot of patients? Well, that's exactly what we're going to talk about today. Okay, so I've worked at two separate institutions that have been collecting this data. I've previously worked at Children's Specialized Hospital in New Jersey, And while working there, they were in the process of rolling out their data collection. Also, I'm currently employed at Phoenix Children's Hospital. And when I started here 2 years ago, they already had the data collection within their system that was very easily accessible for all of us therapists. I've learned a lot about how much the social determinants of health can impact your day-to-day. So here we have the previously seen 2030 social determinant of health graphic on the U.S. Department of Health and Human Services website. I love that quote that Karen shared earlier about the social determinants of health are where people are born, live, learn, work, play, worship, and age that affects a wide range of functioning and quality of life outcomes and risks. So there are a variety of surveys hospitals are using to collect this data. And some of the things that are being screened, but not limited to, items such as transportation, stable housing, food security, and things like paying electric and water bills, as well as emotional health, things that could include postpartum depression or bullying, and childcare. Today, I'm going to talk through the 4 that you see on the left-hand side of your screen and differences that you can make in your day-to-day practice that might help with a plan of care. Also, in approaching this topic here on the U.S. U.S. Department of Health and Human Services website, they have all their goals directly listed, and the icons over here are color coordinated to go with the goals. I did not find one on childcare. However, I may have missed it, but it is one that is consistently #1 on our social determinants of health screeners here at Phoenix Children's and through the Phoenix Children's Care Network. Okay, so I think that every therapist has gotten the call where someone didn't have a ride, they got a flat tire, their car broke down, and they were unable to make it to their therapy session. Now, if we broaden this example to overall unreliable transportation, or maybe somebody has a power wheelchair and needs to take medical transportation to their appointments, we all know that if a patient cannot make it to their therapy session, that we have a decreased ability to help them. Now, ideas that have helped me when I see that somebody has a transportation insecurity on their survey is one, knowing the in-home services in your area. So for example, in pediatrics, many states have an early intervention program. So if you're like me and you work in an outpatient hospital-based program, and you see that on the social needs screener that the family has a determinant in transportation, maybe you talk through this with the family and determine a plan of care that works best for them. So for example, if they needed a stander, maybe they have 2 to 3 outpatient hospital visits, and then you work with the EI therapist in their zip code to then transition them to in-home services. Another option that greatly assists in instances of transportation is the use of virtual or telehealth therapy and on-site therapy. If in your state you're able to provide virtual or telehealth therapy, this can greatly decrease the transportation burden. Maybe a plan of care is every other week in person and every other week over telehealth. Not only does this decrease the transportation burden, but it may also help you see inside the patient's home and provide them with insight into the area that they navigate on a daily basis. Lastly, in New Jersey, Children's Specialized Hospital actually worked with the medical transportation company that were inconsistent when they were bringing patients to appointments, and set up a program where if medical transport was about 15 minutes late, the family could then call a Lyft and then they would be reimbursed. I do think this is a great program to look at helping them get to their therapy appointments. The families then did have to have that money to pay up front, and it would take time to get reimbursed. So that kind of adds some other variables, but I thought this was a nice workaround when somebody had to take medical transportation. So these are some small changes that could make a really big difference if a patient is able to receive more appointments recommended for their outpatient plan of care. Well, I know sometimes it's easy to think that in person and with one therapist is best, but utilizing alternative methods to assist the patient in meeting their set frequency, not only can we help them meet their goals, but we're building patient rapport and buy-in as you're meeting the family where they are. So at Phoenix Children's, NES on a social determinant of health screener is an automated social work referral, along with a message listing resources that are specific to that specific determinant in their zip code, which I think is a really helpful thing to help ensure that people are getting the resources that they need. When we're screening for home security, I think it's important to think about a multitude of factors as well, such as accessible housing. So for example, maybe someone isn't in a stable housing situation because they're paying month-to-month rent, anxiously awaiting for a first floor handicap accessible apartment. This may also come up in a discussion when you notice that they don't bring their brand new fancy wheelchair and have their 6-year-old in a stroller instead because the wheelchair was heavy to carry up and down the stairs. So these are things that we can think about to do our best with when we're ordering equipment, but also that sometimes come up a little bit later. Additionally, another way to help with housing insecurity issues are chronic issues like pest control. So at Children's Specialized Hospital, one of the items that they screen for and help provide legal services for is renters' rights in regards to issues like this. Food security can have a large impact on a plan of care as well. Someone is not going to be able to attend your outpatient therapy appointment if they're having trouble paying for food. So if someone has a difficulty obtaining food, they're going to pay their gas money to go get that instead. So having a list of resources to send a family with something in their zip code can be super helpful. Another great example was at Children's Specialized Hospital, in which they noted at the systems level, similar to what Karen was talking about, tracking everything, they noted that one area in specifically had a lot of food insecurity. And what they did was work with that food bank in that zip code and had the food delivered to the outpatient location. So then when the family came to the therapy appointment, they were able to pick up their food from the food bank for that week. So it was really helpful, a nice collaboration. This program was actually so popular that now at Children's Specialized Hospital, they have that food bank service at all of but one of their locations. And they also have diapers available. And they also have diapers for patients that might be receiving public health therapy, which can be a larger size and harder to find and an unexpected expense that you didn't anticipate having. Lastly, a social determinant of health that I felt has truly impacted multiple case scenarios is childcare. It really impacts both the pediatric and adult worlds. An adult can't make their PT appointment if they have children and don't have childcare. And in pediatrics, we have a lot of siblings. So during the COVID-19 pandemic, this was particularly difficult for families where most hospitals had really strict visitor restrictions in both outpatient and inpatient settings. My biggest tip or trick for this one, and to help provide the most equitable healthcare that we can, is to let kids at all be present if that's at all possible. If you have an older sibling in a pediatric setting, little ones love to copy the older sibling. You can have some extra toys on hand for the sibling in the appropriate age range, or potentially have a tech come over and help him watch that sibling. It's hard enough to get one child to a medical appointment. A parent isn't going to bring the whole family unless they really have to. And they're valuing your time and they really want to be there. Making accommodations for this is one of the ways that we can help decrease the economic burden on the family who maybe have difficulty attending the appointment. Okay, in closing, well, at the system level, we can attack the big picture. Do not forget that on the ground, we can make a big impact and help flowers grow in difficult places when we are aware and supportive of our family's big picture. Also, a big thank you to Dr. Jadakin, who and his team, who lead Phoenix Children's Care Network and took the time to talk through the items in this presentation, as well as update me on all the work that they're doing here at Phoenix Children's. And thank you to Laura Higgins, who is the clinical lead of physical therapy at Children's Specialized Hospital, who also took the time to review the presentation content and give me some updates on everything going on at Children's Specialized as well. Thank you all so much for your time. And next, I'm going to pass it on to Devyn.
All right. Thank you so much, Karen and Kelly. I think the funniest April Fool's joke is that I'm going last when they should have gone last, because their presentations were so good. So, but we'll still try and end on a high note. So my name is Devyn Woodfield, and I am the data analyst supporting rehabilitation services at Intermountain Health. And I am not a physical therapist by trade. My background comes from a more technical background in statistics. But I have come to understand and love the rehabilitation discipline I've developed many reports and analytics for rehab and including some aspects of social determinants of health. So I'm going to go over some of those aspects. So at Intermountain, we are a large non-for-profit health system based out of the Intermountain West, out of Salt Lake City. We got over 60,000 employees. 1,900 of those are rehabilitation caregivers. We got over 200 plus data and analytics professionals. So I'm just one of many. But I'm going to be kind of focusing in on the rehab piece of analytics and social determinants of health at our system. So really quickly, just a simple overview of how the data flows in our system is we've got data coming in from all over the place, from the EMR, registration, billing, we got patient report outcomes, you name it, and it all flows into an enterprise data warehouse in our system. And we have a whole separate team of data architects, and that's their job, is to get it from where the data is entered and to a central repository into the warehouse. And then my job is to essentially grab the relevant data and bring it to the surface in a dashboard. The tool we use is Tableau, but there are many data visualization tools out there that could be used to help visualize this data. So we've been able to create a lot of cool things like access metrics to quality and patient experience, discharge settings, census, volumes, you name it. I try to throw a big sampling of reports on here just to show that we've got a broad spectrum of reporting in our system, and the infrastructure that's been put in place allows us to kind of be very data focused and make a lot of data driven decisions. So now let's shift gears and talk about social determinants of health. So within Intermountain, this is being collected in the outpatient, emergency department, and inpatient settings. For the adults, we use a social check screening tool developed in-house, and we also have, in the pediatric setting, we use the SEEK tool, Safe Environment for Every Kid. And so these screenings, they're done in person by care management, but in addition to that, we have automated screenings that are being sent to these patients. The tools we use are Notable or Freesia. And once these, maybe a social determinant is identified, these patients are connected. We partner with Unite Us to connect these patients to the right resources. And something unique to Intermountain is we have a subsidiary company called Castell. It's focused on value-based care, elevating your value-based care capabilities. And as part of that, they have social care coordinators that can serve as a sidekick to care management to help also connect these patients to the right setting. So using all the data that we're collecting, right now we're kind of in a phase of looking at more of compliance. Are we collecting it at all the different settings? This is kind of phase one. We're really good at it in outpatient in our primary care settings. In the inpatient setting, we're growing and evolving and learning in the inpatient setting right now. So that's kind of phase one, is let's collect this data consistently across all the settings. And so we've got this dashboard that lets us look at, by facility, who might be lagging behind or excelling ahead. How are we doing over time? And this dashboard, you can drill down to specific details to help elevate everyone to be collecting this consistently. This dashboard at the system level, again, this is system level, not rehab specific. So this allows us to see, what are the most common social determinants that are being identified, and so we can act appropriately on those. So now, honing in on rehab, here's kind of our own journey through rehab. So we started with what we called the Rehab Equity Dashboard. And what this was designed to be was a tool for rehab leadership to just get in and kind of play around like a sandbox to find out maybe potential disparities in rehab. So the way it was designed is you could filter to, any scope you can imagine using demographics and location and diagnosis and outcomes. And so you can hone in on the population of interest, and then you could choose a metric, and you can choose up to 3 variables, and you can see how that metric breaks down by those variables. So it was a great tool to kind of get around, play around, see if we could find any disparities. We actually didn't find any huge disparities, which at first we were disappointed, but then we realized that's a good thing. We don't have any huge disparities in our system. But then we started thinking, these are all our patients that we did see. So then we started thinking, looking further upstream, what about the patients referred to us to rehab? What percentage of those are actually making it to therapy? And are there any variables there worth exploring? One that did come to the surface, it's not a huge disparity, but it is statistically significant. We looked at the area deprivation index, which is a metric based on variables that can be extracted from US Census data, looking at income, education, employment. And we found that those that were most deprived of this most material deprivation were less likely to attend therapy. And those that were least deprived were more likely to attend therapy. So there is some significance in there, and this is literally, where we're at. And, next steps are kind of to dig deeper into this using the more rich social determinants of health data that we're collecting now. So this was one of our first dashboards that was looking at social determinants of health. And I show this just to show how, it can be pretty simple. It can just be a bar chart or a line chart to get started to tracking this from a data perspective, to see, what percentage of your patients have transportation needs, or what percentage have family support available. If there's a dip in the data, why did that happen? What can we do with it? So that takes us to our current state. We're going to continue to promote and utilize these social determinants of health in all care settings. We're going to try and make this a lot more visible in the medical record. At Intermountain, we're going to be switching to Epic next year, so we'll be able to use some of the tools that come with Epic in that sense. And then we're looking forward to moving on to phase 2, which is, we've got all this rich data in the database, and now we're getting more and more consistent at collecting it on all of our patients. And now the next step is, let's look at some metrics. Let's look at readmissions, outcomes, downstream costs for these patients, to see what trends come to the surface, and then most importantly, to act on those insights so that we can truly make a difference for the patient. So